Welcome to Decoding DX. We are back after our holiday break, and we have an awesome case tonight of chronic diarrhea that John is going to present for us. Our discussants tonight are Dr. Stephanie Slimmer, who is a PGY-3 internal medicine resident at KU, and then return awesome M3 discussant of Sara Ohadi-Hamadani, who is also joining our team starting now in January. So to start out, I will have Stephanie and Sara just tell us a little bit about yourself, where you're at in training, and something about you that does not involve medicine. Stephanie, we'll start with you.
Okay, so my name's Stephanie. I'm a third-year internal medicine resident here at KU. I did my med school at KU as well, and planning to do a chief year next year. And that's something about me not related to medicine. I guess a fun fact about me is that I have never had a brain freeze before, and like ice cream is my all-time favorite thing to eat. So it's actually kind of amazing that that's happened. So
that's awesome. I've always had brain freezes all the time, and I hate it.
I've heard they're painful, but I don't know.
Maybe you eat slowly, that's why.
I don't. That's what people say, but I really don't. I don't know. My dad apparently has never had one either, so.
I'm Sara Ohadi-Hamadani, and I'm an M3. I guess 4 facts. Let me see. Sorry, 1 fact. I have 4 cats is what I was saying. My brain is a little off today, guys. Sorry. But yeah, 4 cats, 2 boys, 2 girls. And one of them's feral. We're a weirdo. So, and 2 of them are brothers. So we have 4 cats, and I love them. They're so cute and cuddly.
Okay, so our case today is an 83-year-old female. She's got a history of coronary artery disease, HFpEF, SVT, and advanced dementia, who is presenting to the ED with 2 months of persistent diarrhea. So, Sara, starting with you, you hear someone coming in with diarrhea. Can you kind of talk to me a little bit about what you're thinking when you first hear the chief complaint of diarrhea from a patient?
Yeah. So of course you want to know how long it's been going on, and is there blood in the stool? Is there fever with it? Any abnormal vital signs, of course, like making sure that they're stable. First, of course, like the ABCs, and usually they probably are, hopefully, if it's chronic diarrhea, but I guess just watch for the ABCs first. So there's no like signs of an infection or anything. And then I'll go ahead and ask some questions with how long it's been going on. Is there any abdominal pain with it? Like basically old carts, and like go down that list, and then history, of course.
Mm-hmm. Yeah. And then anything in particular kind of in that one-liner that makes you think that this might be an interesting encounter or different than a typical patient encounter?
Yeah, the patient has like heart disease, coronary artery disease, and heart failure with preserved ejection fraction, SVT. So all of that kind of makes me think differently of it, and it's been 2 months of it, so it's not a chronic thing, but it is a chronic thing technically, but it's not like long term chronic. And then potentially, is the patient with dementia, who's their caregiver, and are they taking medications, maybe mismanaging their own medications? Who's helping them? I didn't know if they came from a facility or not. Sorry if I missed.
Yeah, no, and this is just kind of one of those things where you see like a consult, or you see an admit something, and you say, okay, what's going through your brain? Stephanie, is there anything else that you'd add to that, just from that real quick one-liner, things that's going through your head?
Yeah, just like Sara said, with the dementia, it's very important to get information from a secondary source, whether that's the facility or a family member. And then in addition, just knowing that she's like an 83-year-old usually rules out some things, such as like possibly autoimmune problems. But 2 months would definitely need to be clarified. And then just having someone able to characterize the stool and give a little bit more information would be helpful. And then also, like Sara said, making sure vital signs are okay. Anytime someone comes in with diarrhea, even if it's acute on chronic worsening, you want to make sure, they're not hypotensive from the diarrhea, they're not tachycardic from losing a bunch of fluid. So.
Yeah, absolutely. That's a great place to kind of start. And in the chat, we also had a schema was added from Clinical Problem Solvers from Drew. So that would be a good thing to check out as well if you're wanting to see that. So a little bit more of history of present illness. So she, with the advanced dementia, she isn't able to care for herself at home. So her son is who takes care of her. Generally speaking, any of her short-term memory is not there anymore, and she really relies on her son for just about everything. And he's the one you are getting all your history from. You kind of you said hello to the patient, but she doesn't really know where she is, doesn't really know what's going on, and is kind of just looking at her son to kind of give all your information. So most of this stuff you can, I guess, assume is more accurate because he's a caretaker, he's helping her, and has witnessed the stool occurrences as well. So the diarrhea, he reports, has been going on for roughly 2 to 3 months, but it has specifically gotten worse in about the last week. So in the last week, he's seen it getting worse, and maybe she had a little bit less appetite. And in that time frame, that's kind of what led him to actually come to the ED. So that's where you're seeing this patient. He reports that on average each day she's having 8 to 10 bowel movements. They're watery and non-bloody. He hasn't seen any blood in her stool, at least recently. In the distant past, she did have some diverticular related bleeds, but hasn't had one of those in a really long time. She also is known to have to wake up multiple times during the night to defecate. He isn't really sure if she has any abdominal pain. Mostly seems like she's doing fine, and she normally sits pretty comfortably, but she doesn't really know. She can't really answer the question very well. If you ask her if she has abdominal pain, she just says no, but she says no to a lot of things. She doesn't have any recent travel, doesn't have any associated sick contacts or other changes in her diet or other people having similar symptoms in her family. And then of note, she's had multiple admissions over the last year. They've largely been related to her supraventricular tachycardia. She's had runs of SVT, that she's had, some syncopal events and some other things. So it's been mostly cardiac in nature, but has been having this kind of diarrhea has kind of slowly come on. But she's been evaluated it, but she wasn't her chief complaint coming in prior to today. And then I'll kind of stop there, and we can talk a little bit more about the other things that they did in the past. But kind of, so Sarah, based on that information, how would you classify her diarrhea? Particularly acute versus chronic is kind of what I'm thinking about.
Oh yeah, so I think it's 2 weeks. Okay, because I kind of was looking at this just like 10 minutes before we started. So I thought 14 days and less is acute. There's also a persistent diarrhea category. I didn't quite finish remembering that, but I know a greater than 30 days is chronic diarrhea. So this is chronic diarrhea characterized, I guess.
Yeah, and kind of based on this info, we'll get a little bit more information after we kind of talk about what we're thinking based on the previous admissions. But what are some things that are kind of on the top of your differential to start with?
Oh, for me?
Mm-hmm.
I'd say, this is a tough one. I'll put infectious, potentially. I don't know. She's not febrile, right? We don't have that yet.
We don't know that yet.
Good. Okay, I'll just say infectious. Maybe, I guess, like kind of like a cancer, something thinking about potentially, I don't know, something like, or thyroid, I guess you can say hyperthyroid as another one. And I don't know, maybe like an osmotic thing, or if they're taking like laxatives by accident or mixing up medications. Maybe they're taking too much Miralax or something.
Yeah, absolutely. That's a really great list, and it's those are kind of those big things. The thinking about infectious etiologies, thinking about there's multiple like neoplastic type syndromes that can cause diarrhea, and then medications is a huge one, and oftentimes can be something that people overlook. Stephanie, is there any other things that you kind of jumped out from that basic history that makes you think maybe one of those more so than the other one of the kind of the list that we have thus far?
Not specifically, I mean, without like labs or vital signs or anything like that, but definitely infectious and cancer come to mind first because those are pretty common. And then in the infectious column, I would probably say C.diff always comes to my mind first because I see it so much in the hospital, especially most patients her age coming from a facility. You really have to have that in mind because it spreads very easily. And then obviously with her age, I would also have cancer probably pretty high up there, just given the fact she's 83.
Yeah, absolutely. So we'll give a little bit more history now. I'll give a little bit more history about her evaluation that she had prior to this current presentation. So she got an infectious workup, which we'll talk more about in a second, but thus far that came back completely negative. She got CT imaging at the time that showed some wall thickening of the transverse colon to the rectum, and then some diverticulum, which has been known. She's had a course of empiric antibiotic therapy with cefpodoxime and metronidazole for a week, and then also was started on Imodium after an additional infectious workup. So this is something that's kind of been noted, but it hasn't been the chief complaint until now. And she really hasn't had much improvement with the Imodium either. So some additional past medical history. So she has the history of the coronary artery disease and STEMI, and she has had an abnormal stress test in the past. So she's been on aspirin and metoprolol. She has the recurrent SVT, which is currently being treated on with dronedarone or Multac. And then she also has HFpEF, which has been noted on echo, which shows normal ejection fractions, but so with some mild diastolic dysfunction, but hasn't had any symptoms of that. And then also she follows with the neurologist for her Alzheimer's, and has been on donepezil for about, she said her son thought about somewhere around a year at this point. She no real significant past surgical history. Social history, she's retired, lives with her son at home, doesn't go to a facility or anything like that, hasn't traveled recently, and then no history of tobacco, drug, alcohol use or anything like that. Her medications are, like I had mentioned, dronedarone, metoprolol, aspirin, and donepezil. One thing that is important to note is that when we looked at her chart, her dose had been actually upped from 5 to 10 milligrams of the donepezil in the past about 4 months or so at this point. And then we'll go ahead and give the vitals, and then we can kind of talk a little bit more about the physical exam. So her temperature was 37.2 degrees Celsius. Blood pressure was 113/62. Pulse was 82. Respiratory rate was 18. And her O2 sat was 100%. Generally speaking, she was in no acute distress. She was resting comfortably in bed. Her HEENT exam did show some dry mucous membranes, but was otherwise normal. Cardiac exam, no murmurs, no JVD, regular rate and rhythm. Pulm was critical, or was clear auscultation bilaterally. And abdominal exam was pretty benign. No abdominal tenderness, soft, non-tender palpation, non-distended, but possibly had some hyperactive bowel sounds. I personally, when I saw her, thought that there was. The fellow who I saw her with didn't think so. So, you know, it's kind of one of those things. And then you were also able to see a stool sample that was sitting in one of the commodes. And that would just showed it was brown and watery, but didn't show any signs of bleeding. So that's a lot of information, obviously. Does anything from that history draw your attention, Sarah, starting with you?
I'm happy that she has pretty decent vital signs. Just the dry mucous membranes showing that she's obviously losing a little bit of fluid. I don't know what her, like, I mean, she's an adult, so would you do a cap refill or not? But dry mucous membranes, otherwise, but her vital signs are stable, so no signs of severe dehydration or anything. So I think that that's the only thing that stands out. And then I'm happy that there's no abdominal pain, which might be more concerning for given her, like, if she had abdominal tenderness with the diverticulitis in the past, or she had diverticular bleed or diverticulitis.
She had episodes of diverticulitis.
Yeah, so I guess that's good. No left lower quadrant pain. So I don't know. That's I guess a good thing. And there's no blood in the stool either, from what you guys saw. We could no, like, you know, gross blood in the stool.
Mm-hmm. Yeah, absolutely. Stephanie, do you have any additional thoughts from that history or things that drew your attention specifically?
Yeah, so I just looking at her past medical history, some things to note would be, so her coronary artery disease. So anytime someone has that, another thing you always kind of want to think of is mesenteric ischemia. Absolutely. With that, though, you usually have quite a bit of pain. Granted, she's demented, and so patients with dementia don't always vocalize that pain very well. They just might be agitated, which can show pain. And then HFpEF, I don't really see a correlation with anything with her diarrhea. Her SVT, the only thing I can think of there would be like a hyperthyroidism, which could cause both diarrhea and SVT. So that would be something to check. I'm assuming if she's had SVT, that has been checked. And then important things to note would be the no blood currently. That can rule out some things. No travel history currently, so that can rule out, certain infectious things. And then I guess like no history. Some things you always want to think that sometimes get missed is if they have a diagnosis of a previous cancer that's been treated. So if they've had like radiation before, that can cause some diarrhea, or even certain chemos can have a long-term effect as well. And then I know we talked about medications, but it's a couple of specific ones to kind of always keep in the back of your head is any recent antibiotic use. So if this lady was treated for a UTI recently, because that'll make you think C.diff. And then common ones that we see, I feel like magnesium, if they're on magnesium replacements, that's a major side effect, is having diarrhea. And then she doesn't have diabetes, but one just to keep in mind would be metformin is another one people can often have diarrhea with, especially if they're not taking it with their food, with breakfast or lunch or dinner. Trying to think what else. The other thing, and this just comes to mind because I recently had a patient that was started on Multac and had diarrhea. So it's just always nice to, she's on so few meds, you can easily look up causes, side effects, common side effects of those medications. Some patients, not as easy to do when they come in with a list of 30 meds, but with her, I would probably, put it into up to date and make sure that's not a common thing. Especially since that was recently started and it sounds like she's had an acute worsening in her diarrhea.
Yeah, absolutely. Those are really good points. The radiation like colitis is a really, not, I wouldn't say common, but it's a side effect that people have much later than you might anticipate. And so that's something that I know I've seen in my couple of years doing clinical things. So we're kind of going to get into some of the labs here in a second. But Stephanie, can you kind of talk a little bit about what a typical infectious workup would be for someone who comes in with diarrhea? I know it's kind of a long list, but it's really common to see, so you hear someone say on rounds, okay, we'll get the infectious workup. Can you kind of list some of the things that usually you would anticipate seeing or be looking for in a chart especially?
Yeah, so as I've said, C.diff is always on there, especially for infection workup. And then we get like a stool culture, which will kind of show you, E. coli, Shigella. Let's see, I think what the other common ones would be basically anything abnormal that can either cause bloody diarrhea or non-bloody diarrhea. And then a lot of times if it's a chronic thing and they don't have a good answer for it, they will even add on like an H. pylori antigen. Normally you have like GERD-like symptoms with that, but if they don't have a good answer about chronic diarrhea, I've seen that added. And then oftentimes with chronic diarrhea, they'll get like stool studies, which will be like stool electrolytes basically, and they'll be able to calculate the stool gap to kind of help differentiate different types of diarrhea. I've seen stool leukocytes ordered. I think there's some debate on whether those are actually helpful. There's a more recent stool study called, what is it? You can get lactoferrin, which I think is the cheaper version, or what is it?
Fecal calprotectin.
Calprotectin, yeah, that's what it is. And that's really expensive. So I think a lot of times, I think they'll go for the lactoferrin, but I think the calprotectin is actually better in a chronic diarrhea picture. And those things just tell you if there's any like white blood cells present, like infectious, what lead you towards infectious.
Yeah, absolutely. So to kind of go off of that, thank you. That was great. The last time that this patient came in, so she had that full infectious workup, and basically everything from that previous infectious workup came up negative. The only thing that was positive where she had a positive lactoferrin looking for stool leukocytes. So the thought is that there's some inflammation going on, but we weren't entirely sure. But we decided to get some additional infectious things kind of repeat just to make sure we're not missing something. So that included, we got a C.diff PCR, which was negative. And then we sent additional stool studies as well. So we sent that whole panel. We'll get to what those were in a second. And then we also got a COVID test because we don't want to miss that. It was during the after times. And then also we sent off like a stool O&P is another one, and also cryptosporidium and Giardia. Those are really uncommon, especially in an old lady, but you don't want to miss them if that's the underlying cause. So we sent those off. Sarah, would there be additional labs that you would like to get in our patient specific, and can you kind of talk about why?
I guess for her, maybe TSH, just to rule out hyperthyroidism. I know she's 83, so maybe that's a lot less likely, and autoimmune's a lot less likely. But I know, like, is Dramorodion or Dramnoduron similar to amiodarone?
Yeah, it is a similar like technically class 3 antiarrhythmic, but it has less of it doesn't have the iodine, which is what a lot of the systemic problems that you see. But it is not a benign drug by any means, like Stephanie had mentioned.
I don't know, just do it at TSH. Maybe that's wrong to do. We could wait. But yeah. And I don't know anything else on here. I think that's all I can think of at this point. I mean, I know like autoimmune is less likely, but like with the with the lactoferrin, which is like inflammatory kind of active, like inflammation, I mean, you still could develop autoimmune stuff later in life. So I'm something to consider. Like the like with you could have like celiac, well, not celiac actually you can develop late, right? Celiac, IBD, and then also what's the one with lactose intolerance potentially, or just things less likely, but like potentially something further down the line to look into.
Yeah, absolutely. So would you also want to get just like some basic labs as well? I think that kind of comes with that, goes without saying.
Oh, yeah. I'm sorry. I saw the labs that you already heard. WBCs, hemoglobin, platelet, all of that. So yeah, definitely electrolytes for sure. All of that. I assume that was already given. Sorry.
Yes. No, absolutely. It usually is by the time you see somebody in the ED anyway.
Yeah.
So in addition to kind of those stool studies that we sent off beforehand, we also got the CBC and CMP as well. So kind of we'll run through that, and then we'll give some of the values of the stool electrolytes and things as well. So CBC showed a hemoglobin of 13 or 0.4, white blood cell count of 4.5. Platelet count, I did not get written down for some reason, but it was normal. So her CMP or CBC looked good. Her CMP sodium was 139. Potassium was 3.3. Chloride was 103. Bicarb was 19. BUN was 22. And creatinine was 1.21. You were able to look back at her chart and also saw that her baseline creatinine was about 0.8. Glucose was 136, AST was 27, ALT was 20, and alk phos was 51. Also got a point of care lactate in the ED that showed elevated lactate at 2.1. Like I had said, all of the infectious workup was negative. I kind of got ahead of myself there a little bit. We also got a fecal calprotectin in addition to that, and I'll talk about a little bit about that more in a second. And then we also got stool electrolytes. So the stool electrolytes were a sodium of 64, a chloride of 93, and a potassium of 78. So Sarah, do you remember what to do with stool electrolytes? And it's okay if you don't, because it's not something that you use every day.
To be honest, not at this moment. I know we did it in GI arena one year, but I've forgotten it, or I haven't used it a lot in my clinical rotations yet. So please enlighten me.
So Stephanie, do you remember?
I think it's close to your regular osms. So like 280 or something minus, I don't know. I would have to look it up.
Yeah, it's one of those formulas that doesn't, you can't like reason your way through necessarily. So it's the stool osmolar gap, which is 290, which is close to your serum osmolality, osmolality, minus 2 times your stool sodium plus your potassium. And your baseline of what you look at is how is it in relation to around 50. And if it is a lot more than 50, that means that it is likely osmolar, or it's like an osmolar based diarrhea. And if it is less than 50, it means it's more likely a secretory diarrhea. And kind of what that means is that if your osmolarity of your diarrhea essentially is a really high, it means that you're not secreting the anions and the ions and the cations at the same amount that would make it like a secretory, because there's something in the lumen of your colon that's not letting you actually get rid of those osms. But it's a very academic thing that's not really that helpful necessarily, but can kind of help you. So you'll see it ordered, but like, what's the utility? I honestly don't know. But I got pimped on it many times, so I figured I would add it in. So for her, it was 6. So that was consistent with a secretory process, which kind of made sense because we couldn't really think of anything else in her case that kind of would make us think that it's osmolar or that she's ingesting anything else, because she's watched just about all day. Kind of based on that, does anything, Sarah, jump out to you with those labs, particularly the electrolyte aspect?
Yeah, it looks like she's if her baseline's 0.8 and she has a creatinine of 1.21, maybe potentially dehydration. If that could be, or like concentration, like she's very concentrated in her like kidneys, I guess. And then her potassium is a little low. So, and what is the chloride? Oh, that's with the normal limits. The lactate at 2.1 doesn't concern me that much. I know it's above 2, but like it's still 2.1. And with her age and everything, I don't know if there's like, if that needs to be treated like with like fluids or not, you know, for sepsis and whatnot, since she doesn't have fever, she doesn't fit SIRS criteria. And so I think that that's like less concerning for me, the lactate, but I don't know. You guys would be able to talk more about that.
Yeah, I agree with you, Sarah. I mean, her creatinine is slightly up, but with the lactate at 2.1, I'm not super concerned. That's usually just she's a little on the dry side. It doesn't make me think like mesenteric ischemia, where your lactate's usually like 15, and you have ischemia going on. So it kind of rules that out. And then the potassium we can expect to be low. If she's been having this diarrhea, you're going to have a low potassium.
Yeah, absolutely. So that's kind of what we thought is like maybe a little bit of an AKI, but it's probably a pre-renal cause because of her being a little dry, and that would make sense kind of with our exam findings and the fact that she's probably pooping out all of her bicarb, and at the same time, so we have a little bit of the we have a little bit of what looks like a elevated anion gap with the lactate as well, and the probably via the non-anion gap portion of losing bicarb via diarrhea. So kind of our next steps would be, Sarah, would you want to admit this patient?
So this is a clinic patient.
So this is actually an ED patient. I'm sorry if I didn't make that specifically clear.
I'm not sure. I don't know, honestly, with this case. I guess because she's 83 and she has the heart failure and the comorbidity, or heart failure, sorry. Yeah, heart failure and the comorbidities and the medication that she's on. Maybe for further workup, it might be beneficial. And I guess because you could argue that her lactate is 2.1, you could make the argument, even though, so I don't know. I guess if we want to figure out what's going on, but I feel like, I don't know. I really don't know, honestly. I don't think she's like that sick, but I also know she's 83 and that's concerning as well. I'm sure there's some algorithm I'm missing on if she should be admitted or not.
Stephanie, any thoughts?
I mean, I think she would probably get admitted considering this is acute worsening of her chronic diarrhea. And we don't have a real good answer still, I feel like, about what's going on with it being secretory. I would say, I mean, even things like ruling out a neuroendocrine tumor might be something to do, since I don't think we've really done that. But yeah, I think she's at a high risk of becoming dehydrated, and then her low potassium as well. So I think she'd be admitted.
Yeah, absolutely. And what are some things that you think, if you were doing the admission, things that you'd be thinking about or wanting to do in terms of initial management, kind of when you're tucking her in?
I would initially start out giving her some fluids to help with her pre-renal AKI. That's like when I would probably order this second infectious workup that you guys did, like the
yeah,
C.diff, and make sure we're not missing something that didn't show up in the other admissions she had for this.
And would you continue the medications that she's currently on? So she's not on very many medications, so it wasn't a very long like med rec process. But what do you think about those?
If I was going through this and I was admitting her, I think I would probably continue her Multac. She's an 83-year-old with dementia. It's questionable whether she even, needs the aspirin, unless she's had like an MI in the past or something that would be secondary. But metoprolol, her heart rate's looking okay, and I don't think she's super dry. So I honestly would probably continue that as well. I think I would probably continue most of her stuff on admission with, in the back of my mind, knowing that these are potential causes of diarrhea if we don't come up with another answer. Specifically, like the Multac is what I'm thinking. I'm not really sure about the donepezil, whether that has a side effect of diarrhea, but I'm assuming she's been on that for a while.
Yeah, absolutely. And do you think that you would do any initial consultations or anticipate wanting to get any consultations from any of our colleagues, and particularly who, if you're thinking about that?
Yeah, so I think she's actually a pretty good candidate for a GI consult at this point, even like on admission, since she's been here in the past. We have a pretty good initial workup. We've ruled out a lot of the common things, and she's being readmitted for this reason. I think it's probably a good idea to get them involved early.
Yeah, absolutely. So pretty much what you said is exactly what we did. So we started on our 100 mils per hour of continuous IV fluids. We did lactate ringers, though I know that's kind of, you can go either way on that. We consulted GI, and our thought was that she's not a great like colonoscopy candidate. When you look at her, you don't say, yeah, I want to like put her under any kind of anesthesia, but with that multiple secretory diarrhea presentation with potentially some inflammation, what we were concerned about primarily was like an IBD that's underlying that we didn't know about, because that actually has quite a bimodal curve that's not quite as identified. I guess especially when I learned that, I was thinking, oh, like it's kind of your 20s, 30s-year-olds, but it's actually very common for something to happen again in the future. Then also microscopic colitis or some other underlying infectious thing that can only be seen like on a biopsy, essentially. So that was kind of our thought. So we consulted GI, and then also we consulted cardiology, because like you were talking about with the Multac and the dronedarone, we knew that was started fairly recently, and we weren't sure whether that's something that we could maybe adjust as well. So when we talked to cardiology, they agreed to switch the dronedarone. So they stopped the dronedarone and started with amiodarone. So, this one's not really about antiarrhythmic, so we'll kind of keep that short. But basically start with a bolus, and then you do an IV infusion, and then you switch to PO. And then also some other recommendations from GI, in addition to potentially wanting to scope in the future, is that they suggested discontinuing the donepezil immediately, because they thought that was actually the most concerning of the drugs, based on her secretory diarrhea picture and the fact that we had upped that dose at kind of the same time. So their thought was that it kind of was looking like medication related, but the fact that she had the colitis picture on CT was where it was kind of like not sure whether she had that and it was getting better with the medication. And then so it's just kind of one of those things that not sure exactly what it was. One question that I did have for Stephanie, that I was thinking about when I saw this patient the first time was, what do you think about her being on Multac in the first place?
Yeah, so it's really interesting you ask that, because I actually just had the patient I was talking to that got started on Multac. He was, I think, 82, and I didn't have a good reason as to why they would do Multac versus like amiodarone, especially in someone older. You're worried about a lot of side effects with amiodarone, and when they're older like that, you're not as concerned about those side effects. So I don't have a really.
Yeah. No, absolutely. Like that's the thing that was weird about her when I first saw her. I mean, she followed with didn't have like an outpatient cardiologist, so she came in for like episodes of SVT. And then they kind of like were saying, okay, well, we need to start her on something. And so they picked her dronedarone. But in hindsight, I thought it was weird also because there's kind of a black box running on dronedarone for patients with heart failure. It's specifically for symptomatic heart failure. So if you're like a NIHA class 2, 3 and up, it's like you shouldn't be starting this. But it does have less side effects, and that's kind of the idea. So you don't have to worry about monitoring thyroid function, which I should mention, she did have the thyroid workup when she had the initial SVT, and we did check it again, and it was normal. I didn't have that on me, but that was a really good point as well. And so that was just one other thing I thought was interesting. So Sarah, something that's kind of important I didn't want to have lost before we kind of talk more about the colonoscopy that she got. What kind of things would you be thinking about if you were having a conversation with her family about discontinuing a drug like donepezil. I don't know if have you really experienced patients who have been on donepezil before?
Yeah, yeah, I have. And definitely, given that she has dementia and the benefits of it are like, what, 2 months max, maybe 3 for people who have dementia or for patients with dementia. So definitely something to consider. I don't know if it's one that you would have to wean the patient off or if you can suddenly discontinue. I'm not sure with that if there are side effects from sudden discontinuation, but it sounds like according to GI there isn't. But I definitely think it's something that we could probably take the patient off if the patient's been on it for more than a couple of years, especially because it's an anticholinergic. Am I correct? And that's another thing that can cause, like, we all know, like, the anticholinergics are medications that can cause altered mental status and problems with mentation, especially if they're sick or having some other issues going on, that it can like worsen it, or the sundowning in the hospital. So I think it's a good thing to talk to the patient and the family, I mean, because the patient might not be able to, but talk to both and see what they think about slowly taking her off of it, if that will improve her diarrhea and if they're okay with that.
Yeah, absolutely. And so kind of what came with this admission for her, in addition to us trying to figure out what the cause of her diarrhea was, it kind of became a really good opportunity for us to have like a goals of care discussion with the family in general. Because, you know, she'd been coming in for these SVTs, she is on this donepezil, you know, the ability for us to really get a lot of benefit from the donepezil is probably past at this point to start with. And also, you know, I think they knew it was very limited, but at the same time, you know, if it's causing side effects, diarrhea is a very common, you know, issue with having to stop donepezil actually. And there are other options, and we kind of talked to them about that. You know, there's like memantine, especially as they're advancing more so. That's usually kind of a neurology would be the one who's starting that. And she does have an outpatient neurologist that they could talk to. But really, you know, it also came down to, okay, well, is there anything that we can do if we're going to switch Moltac and we're going to switch to something else and we're going to do a different medication? You know, would we want to consider doing an ablation or any other advanced procedures? And so was able to have that conversation with cardiology as well, saying, you know, we don't want to do anything else. We just kind of want to make her comfortable with her diarrhea. So if we can figure out what's causing that and stop that, then, you know, she'd be happy with where she's at. So, you know, that was one of those things that I didn't want to get kind of pushed off to the side to thinking about the underlying cause, because that's really important for a patient like this, especially because you see these repeat admissions, you're not sure. You think someone's had this discussion, but really they haven't, because you're trying to find that acute cause of whatever is going on. So I know her son and her family, I mean, they really appreciated that, and they kind of were getting frustrated with the whole situation as well. As, you know, I think a lot of times with caregivers, you also have some of that as well. Okay, so kind of getting to her additional findings and kind of wrapping up. So they did the GI went in and did a colonoscopy. And one other thing I'm going to ask you, Sarah. So have you ever been on a service where you have a demented or an altered patient who you have to try and get a bowel prep? Have you ever experienced that?
No, but I imagine it's not easy. And for the nursing team or for the family, if they're in the room, and for the patient having to go to the restroom a lot. There's probably a lot of accidents, I imagine, at least. And I also think it's really gross. I've heard from the colonoscopy, people really don't like that, the liquid that they have to drink.
Yes, very true. Stephanie, you made a face while I asked that question. Have you had an experience with that?
So in my experience, actually, like you were saying, goals of care discussions a big thing in this situation. And when you put up here, you know, I knew this was a chronic diarrhea case, and you put up dementia. First thing is like, oh, I don't even know if they would want to do a colonoscopy on this patient for the prep reasons. You know, a lot of times these patients aren't going to drink the 2 liters of Go Lightly that we're giving them. And you have to put an NG tube down them to put it through that, and that causes more delirium. It's a mess, honestly. So I think the goals of care discussion is very important before you get to that point. This family, you know, they're bringing her in diarrhea, they weren't expecting a goals of care discussion to come out of this, right? Because you're talking about stopping medications that may cause her to go to SVT, which then you're talking about, shocking her, defibrillating her, like, are these things she would want if you're stopping these medications? So it turns into a big deal for the family. And kind of going back to that also on stopping, like the donepezil, like, families really hold on to those medications, even though as medical care providers, we know they don't have a lot of benefit in the long run, but to them, that's the only hope they have for their family members with dementia. And so some families are really resistant to stopping those medications just because they don't have any other options, as we know, for dementia. So.
Yeah, no, absolutely. And that was kind of the situation with this patient, is we kind of knew that she wasn't going to have a very good I mean, she had the diarrhea, but she wasn't like cleaned out. So we knew it was probably going to be a poor prep if we couldn't get her. So we ended up doing like a prolonged prep, which is an option that you can do for some patients if they can't drink 2 liters at this one point, that you can kind of slowly go and do. And we knew she's going to be there for multiple days because she was a complicated patient. I kind of even though she's complicated now, there was even more stuff going on, and she had episodes of SVT while she was there. So we knew that this was not going to happen immediately. So we had time to get her prepped. And so this was not an overnight. We got her going, and then she was good to go. So this kind of took a little while. So, but we finally did get her prepped. I think she got her colonoscopy. And so I'll kind of just read the report that they found. So there was perianal, and the digital rectal examination showed anal fissuring, 2 anal fissures specifically. And then on scope, they saw diverticula in the sigmoid colon, and then patchy areas of severely erythematous mucosa throughout the entire colon. And a portion of the transverse colon and a couple of sigmoid. They kind of do a random biopsy pattern for those to rule out any CMV or microscopic colitis or IBD type of inflammatory processes. And the biopsy came back showing numerous crypt apoptosis and occasional apoptotic crypt abscesses. And so when I read that, I said, I have no idea what that means. I'm not a GI histopathologic whiz. And so I went straight to the GI fellow and said, okay, what the heck does that mean? And he basically said that's the pathologist's way of saying we don't exactly know what it is, but it's not, IBD, it's not a viral, it's not a granuloma, it's not dysplasia. And that's usually what they'll say when they can't figure out specifically like what medications would cause like an irritation. And so oftentimes that's what you will see with like a medication related histologic finding. And then when I went back to look at this case again, I actually saw that there was a note from the pathologist that I didn't see initially. And they said the patient's history of secretory diarrhea is of uncertain etiology. The biopsy shows prominent crypt apoptotic bodies and occasional crypt abscesses without evidence of active inflammation, viral inclusion, or microscopic colitis. These findings are non-specific, but may be related to medication side effect or colonoscopy bowel prep. And they said that there's no specific histopathologic findings related to the donepezil, but they suspected that that's what the cause was from that histologic finding. So it's kind of an unsatisfying diagnosis, kind of a diagnosis of exclusion, but we kind of gave an option and a treatment plan for her. So following that, her biopsy and colonoscopy, her with IV fluid resuscitation, her AKI improved significantly. She was able to transition to solely PO and was able to keep up with that. We upped her Imodium even more, and that helped as well. And then she got to kind of the point where she was maybe having 1 to 2 bowel movements a day. They were still kind of watery, but they wasn't as much volume. And important things is that we got her set up with outpatient follow-up from her neurologist with where changed to donepezil, a cardiologist to kind of monitor her SVT. Like I mentioned, she had a lot of stuff going on on the heart side of things during this admission, and then her PCP as well. And then my last follow-up looking at her chart, she was started on memantine by her neurologist and is currently not having any issues with diarrhea now. So You know, she's kind of still dealing with, you know, the heart things and the dementia, but luckily, and for her family, I think it's been good is that we've been able to kind of curb that diarrhea, which was good to see, because I was, you know, you don't always see a good outcome with a chronic diarrhea patient, especially one with the underlying neurologic dysfunction. So not a super exciting case per se, but you know, it's one of those that you'll see, no doubt, when you are on the wards, for sure.
Yeah, that's a good case, John. Can I add some like practical things I thought?
Oh, absolutely. Please do.
Just related to the wards, I guess, mainly. So I guess, especially when you're on nights or cross covering, you'll get calls about like diarrhea all the time. Like, oh, this patient's had 7 stools today. It'll be midnight, right? And you're like, oh, I don't know anything about this patient. I need to go look them up. The nurse will always ask for like Imodium. Can we give them something? The biggest thing you have to just remember when you get in that position is that you've ruled out C. diff. So before you start Imodium. So you can't start Imodium because you're risking toxic megacolon if they do have C. diff. So it's just important to get that negative test. In the hospital, actually, they cannot test for C. diff unless they've had 4 loose stools in 24 hours, and they have to be like watery. And then they can't be on any laxatives for 24 hours. So like no Synacot, no Miralax, which all, you know, most patients are on in the hospital, but you definitely have to stop those and say, yeah, they're still having diarrhea. That's not the cause of it. So make sure you rule out C. diff before starting Imodium. And then another thing that I feel like I never learned about in med school, but once you get to the wards, you'll hear it every so often, is the Bristol stool chart, which I don't find it very useful because they can say, yeah, it's a 3, and I still have to go look and see what that even means. But you will hear that, and it's basically a chart from 1 to 7, I think, and it just goes from 1 being like brown balls to 7 being liquid. So just something to know. And then I think in this case, I know we had quite a bit of history just from her previous workup and stuff, but you would definitely like want to, if this is a new presenting case, like things to keep in mind is it affected by food? So that's a big thing. And then also knowing if they have abdominal pain or diarrhea during the nighttime. So you'll see a lot of IBS once you start your clinical practice, and that's a big one to keep in mind. Is usually with IBS, they don't have stools, they don't have abdominal pain during the night, and then food will help you kind of determine specific causes as well. If pain is worse with food, the diarrhea is worse with food, like malabsorption causes the gluten intolerance, lactose intolerance. A lot of times if you're having chronic diarrhea in the outpatient or inpatient setting, you can check vitamins like B12, iron, B1. Those will kind of help you determine whether this is like a malabsorption issue or not too.
Yeah, absolutely. Those are really great points. And there's a really good paper that Dr. Grisolano, who's a gastroenterologist at KU, he's really nice and really a good teacher. He gave to the residents and medical students who were on the service that I was at that time about diarrhea and the workup. It's like a really good case-based approach to how to think about diarrhea and how to kind of stratify it and walk through a few cases as well. So I found that really helpful and kind of gives you the breakdown points of where you need to be thinking different directions and when to be ordering certain tests, which I find helpful to have someone kind of walk through, because I'm kind of a case-based person to figure things out. So, all right, well, that's pretty much it for me. Brianna, do you want to kind of break down any big teaching points?
First of all, guys, that was awesome. That was a really great discussion. And Stephanie, I really appreciate the little practical things at the end there that you wouldn't really otherwise pick up. So I really appreciate that. I think just a few things that really stood out to me. I really appreciate, John, how you kept coming back to the patient and her experience, because we know that her dementia is going to really affect how she experiences being in the hospital. And so keeping that as central to her entire care, I think, is critically important, because in the end, it's just about our patients. And if they are suffering, whether or not it's quote unquote for their good, that's not for their good if they're suffering. So really doing anything that we can to do what they need for their care. You know, you guys gave us a lot of great approaches to chronic diarrhea. I think those were very well laid out, and I really appreciated the way you guys walked through it. Obviously, wonderful clinicians that you are or will become. And yeah, I think just another thing that stood out is just kind of having alternative options available. So one size doesn't always fit all. And that falls into the category we were talking about with dementia, but other patients too. Sometimes things just don't work for patients, and whether that's a medication or a way of bowel prep or something else. So just keep flexible minds on, and we'll all be better for it. So thank you all so much for joining us. Really appreciated the conversation. You're all awesome, and just stay safe, stay healthy, and join us back live in 2 weeks, and then other weeks live on YouTube.